I'm going to ask, there you go, folks on my team to hit record and ask my colleague Jasmine Joseph to please go ahead and share the slides on her screen. And we will get started. Hello, everyone. My name is Stacy Chazen, and it's my pleasure to welcome you here all today on behalf of AIDPH to this exciting webinar, which is the culmination of a student fellowship that AIDPH had this summer for 4 outstanding participants who you're all going to hear from today. So before we get started, I'm going to go over some housekeeping items. As I just shared, today's call is being recorded, and we'll be posting the recording on AIDPH's website after the event. We'd like to ask everyone to please add their pronouns to their Zoom name if they're comfortable doing so. Please also add your organization and location to the chat so we can be aware that you joined us today. We're going to also let you know that all slides and any other materials that are referenced today will be available on the AIDPH website as well. So next slide, please. The learning objectives for today's webinar are as follows. Participants will be able to describe trends in oral health markers and physical outcomes of veterans by income and rurality, to be able to understand the impact of the Paycheck Protection Program on veteran-owned dental businesses, to gain insight on current literature on veteran oral health that can inform a best practice resource for community stakeholders, and gain insight into the knowledge, comfort level, and biases of dental professionals and educators around the LGBTQIA+ community. Next slide, please. The presenters of this webinar declare that they do not have a financial arrangement or affiliation with any corporate organization offering financial support or grant monies for this continuing dental education program, nor do they have a financial interest in any commercial products or services they'll discuss in the presentation. Next slide. So what is this fellowship we're talking about today? The AIDPH Summer Research Fellowship was a 10-week program that supported participants in developing their skills and conducting a research project related to advocacy for special populations, including veterans, the LGBTQIA+ community, and oral health for individuals in rural communities. Next slide. The fellowship itself included a number of components that were all completed virtually. We supported the participating fellows in career development with the opportunity for participants to meet one-on-one with oral health leaders around the nation, including the AIDPH Board of Directors and members of the Corporate Leadership Council, including Eric Shirley, who's with us today. So thank you, Eric, for that. The educational and research experience was designed to align with the participants' individual interests and career goals. We also supported the fellows to help cultivate AIDPH's Dental Public Health Virtual Resource Center. So they looked for resources to add to that site, and excuse me, also provided guidance and training around how to run a national nonprofit while supporting the programming of AIDPH. Next slide. So here are our summer fellows, and I'm going to give you a brief introduction to them right before each of them presents, so it'll be fresh in your mind. If you could move us to the next slide, please. Great, and so that is what we're going to do right now. And before I introduce our first speaker, I'm going to ask folks to please post any questions in the chat box that they might have. Please keep yourself on mute for the duration of the call. We're going to cover questions after all 4 of the fellows have presented. So at that time, we'll invite you to take yourself off of mute and ask a question, or to post your question in the chat box, and then we will moderate it. So we're going to get started with our first presenter, and I'm going to tell you a little bit about her. Pamela Wachukwu is a dentist, dental public health resident, and PhD candidate at the University of Iowa. Her research interests include health services, health economics, and health policy research. Her career goal is to promote access to oral health care for underserved populations through research and public health dentistry. And it's my pleasure to turn the microphone over to Pamela right now.
Sure, thank you. Good day, everyone, and thank you for joining us today. I'm going to be talking about my project for the 2022 AIDPH Fellowship, and it was an analysis of veteran oral and physical health outcomes by income and rurality. Next slide, please. So 2 in 5 veterans report suboptimal oral health, and this translates to about 8 million veterans in the United States. We're also seeing that veterans are experiencing higher rates of tooth decay than non-veterans, especially rural dwelling veterans. And these people are experiencing worse health conditions. They've been historically found to have lower incomes than urban dwelling veterans. And we know that these are all social determinants of health. They're less likely to visit the dentist. They've been also found to be more likely to lose their teeth. And all of these have compounded the issue of poor access to dental care, especially for veterans. Next slide, please. So we sought to answer the question, what are the geographical differences in oral health markers and physical health outcomes by income and rurality among veterans? We used the 2021 Veteran Oral Health Survey, which was fielded by AIDPH between September and November of 2021. It was a convenient sample of active duty and separated veterans. We had about 2,000 respondents, and we asked questions relating to oral and physical health outcomes, income, ED use for dental care, and out-of-pocket costs for dental care. So we pulled rurality and dental health professional shortage area info from the Rural Health Information Hub, and these are designations by HRSA. And then we conducted heat mapping and density scoring of oral and physical health conditions by rurality. Next slide. So our outcomes were veterans who had at least one of the listed oral health conditions and at least one of the physical health conditions that are listed on the slide. Next slide, please. So when it comes to income, we're finding, if we look at the star chart, we're finding that the largest percentage of respondents had incomes between the $30,000 to $60,000 range, and about 19% of veterans earned under $30,000 per year. So pretty much half of veterans earn under $60,000 per year. I just want to highlight the fact that 11,000 veterans, and if you generalize this to the veteran population, that's about 2 million veterans have never visited a dentist. We're finding about 80% of veterans reporting paying at least $500 out of pocket for dental care. 87% of veterans had at least one oral health condition, and 61% of veterans had at least one physical health condition. Next slide. So when we looked at rurality, dental health professional shortage areas and their relationship with oral health conditions, first we're seeing an overrepresentation of veterans in rural areas. We're seeing that about half of veteran respondents resided in areas with dental professional shortages. And when we conducted chi-square tests, we're seeing significant associations of oral health diseases with living in rural areas, and veterans who live in dental health professional shortage areas. Next slide. So when we asked about self-rated oral health, we're finding that veterans who lived in rural areas were more likely to rate their oral health as poor to average. Likewise, veterans who lived in dental health professional shortage areas were also significantly more likely to rate their oral health as average. Now, when we compared the number of veterans who were rating their oral health as poor to average by urban versus rural areas, we can see higher percentages for rural dwelling veterans rating their oral health as poor to average. Next slide. So this is just a map that shows veteran oral health conditions by rurality. So the darker shades show the greater proportion of veterans who live in rural counties in that state. And then the percentages show percentage of veterans who had at least one oral health condition. So we can see the darkest shade right there in South Dakota. And then they have about 78% of veterans who had at least one oral health condition. But then if you look at this map, you find out that even the states that had lower rates or lower percentages of veterans who resided in rural areas, they still had significantly higher rates of oral health conditions. So next slide. We're seeing a similar pattern for physical health conditions also by rurality. Generally, lower rates of physical health conditions compared to oral health conditions, but similar pattern where both states that had a significant number of rural counties or veterans living in rural counties and states who had lesser number of veterans living in rural counties having high rates of physical health conditions. So next slide, we'll just discuss a geographical differences also in veterans' oral health conditions by states' median household incomes. So the lighter shades show the states with lower incomes compared to the darker green shades with states with higher incomes. So we can see some states even having 100% of veteran respondents stating that they had at least one oral health condition. But then if you look at states like Washington and California, they still had about 86, 87% of veterans reporting at least one oral health condition. Next slide, we'll see similar patterns also with physical health conditions, though generally lower rates than oral health conditions. So what this is generally telling me, next slide please, is that while income and rurality may be drivers of disparities in oral health conditions and physical health conditions experienced by veterans, it's a nationwide problem. And there could be problems, beyond just income and rurality. There's problems of access, especially considering the fact that veterans have really strict dental benefits under the VA. Our findings are highlighting the representation of veterans in rural areas where there's a ton of barriers to access to care, especially oral health care. We're finding similar patterns with complex health conditions in veterans, inequities by income and rurality, especially in rural dwelling veterans, are highlighting the underutilization of dental care by veterans and overall poor health status of veterans nationwide. Next slide, please. So with this data that I've just presented, we're hoping for continued advocacy for medical and dental integration as a model to increase access to care for veterans. We're hoping that the relevant authorities can consider these rates of disease conditions in veterans and expand access and eligibility criteria for veterans for dental coverage. We've seen increasing rates of veterans utilizing federally qualified health centers and rural health centers as their dental homes. So if the role of federally qualified healthcare centers and rural health centers can be expanded, we can provide more access to care to veterans. And in addition, we're hoping for additional data collection such that the solutions that we're talking about for these problems are data driven. Thanks. That's all I have for today.
Thank you very much, Pamela. And folks, just a reminder, please put any questions you have in the chat for Pamela, and then we'll come to them at the end. Now we're going to turn to our next presenter. We are going to have, hold on, I want to make sure. Okay. We're going to reshare the slides here. Give us 1 second. And I'm going to introduce you to our next speaker while the slides are coming up. So our next speaker is McAllister Castelas. McAllister is a dental public health resident with experience providing care in federally qualified health centers. She previously worked as a lead dentist at a community health center in Wisconsin and dental director of a community health center in Virginia. Before entering clinical practice, she graduated from Boston University with her DMD and completed a general practice residency at Lancaster General Hospital. McAllister is an active advocate for alternative care models, including teledentistry and mobile dentistry, as a means to increase access to care and create an equitable oral health system. And McAllister, will turn it over to you.
Thank you so much for that introduction. And I'm excited because Pamela has set me up really nicely for what I want to share for my research project. So thank you for that, Pamela. So as we kind of saw at the end of Pamela's presentation, she had highlighted this opportunity for engaging veterans in federally qualified health centers. So that is what a lot of my research project this past summer has focused on. So we'll go to the next slide, please. And just to kind of review a little bit of background information. So there are 19 million veterans that live in the United States. And of that 19 million, about 9 million are enrolled in the VA healthcare system. And of those 9 million that are enrolled in the VA healthcare system, only about 15% of veterans are eligible for dental care through the VA. As Pamela alluded to, there are a lot of the access to healthcare in the VA healthcare system is dependent upon service-connected disability and some other eligibility criteria. And just because you're eligible for medical care at the VA doesn't mean you're going to be eligible for dental care. So it's a fairly complex system that these veterans are navigating, and not many of them are actually able to access care through the VA. We do know that about a quarter of the veteran population currently resides in rural communities. And we have seen in recent UDS data that close to 400,000 veterans were seen in FQHC setting in 2021. However, we don't necessarily know which services veterans are accessing at FQHCs. Are they medical, behavioral health, dental? But we do see that this is a point of care, a point of access to care that veterans are now actually exploring. As Pamela highlighted, there's a very high disease burden within our veteran population, especially relative to their general population counterparts. About 56% of veterans report active tooth decay, and about 42% of veterans report active gum disease. In addition to that, there's in a recent survey of about 10,000 veterans, 53% have reported chronic physical conditions, and 33 reported chronic medical conditions as well. All of this I'm kind of highlighting because we do know that there is a connection between our oral health status and our medical status and our behavioral health status. So these are some things that we want to consider when it comes to treating veteran oral health population. And FQHC is actually in a really unique position that help them achieve this, as they often embrace that integrated care model. So being able to treat a individual as a whole person rather than just bits and pieces of their health condition. So all that being said, so that's lots of great information, but what does that actually mean for FQHCs and engaging with veterans? So we'll go to the next slide, please. And what we want to look at is actually starting to identify evidence-based practices to help improve the quality of care and the clinical outcomes, and that have a positive social impact for this population. So when we're thinking about how we identify evidence-based practices, this lovely little pyramid, and for our colleagues who are on research, we kind of think about when we get up to that gold standard, when we're talking about what's most ideal, the best practice, there's certain criteria that are going to be that, versus we move down that pyramid and it's going to be more of a promising practice. So we might not have as much information or not as much long-term data available, but we do see evidence of a promising practice. And then finally, this idea of an emerging practice. So a new idea that we would like to explore further with how we could better serve the veteran population within the FQHC setting. So we'll go to the next slide, please. So what we wanted to think about was when we're talking about identifying best practices for the veteran oral health population in an FQHC setting, first we want to start off with actually a thorough search of current literature regarding the evidence that exists. The short answer for that is there isn't a whole lot of evidence, unfortunately, that evidence-based practices when it comes to veteran oral health and FQHCs, but we wanted to confirm that with our literature and conduct an environmental scan. We also wanted to look at what exactly defines a evidence-based practice and be able to consider any sort of relevant questions when it comes to the identification of what would make a practice a best practice versus a promising practice versus a emerging practice. And then finally, being able to organize these practices into categories. And one of the themes that we had throughout this process is we kind of have this funnel that we take. We have these really big ideas of veteran oral health, but what does veteran oral health mean? And how are we going to bring that down into kind of these smaller little categories? So we'll go to the next slide. And I want to kind of highlight how we move from this big concept of veteran oral health and a promising practice or best practice into what we actually are looking at. So from a practice standpoint and the categorization of the practices, there were three big themes that emerged during our environmental scan. Those three themes were included patient recruitment, personalized communication and front office excellence, the clinical care delivery itself, and then finally, patient and community engagement. So how do we engage with veterans? How are we actually delivering the care? And then looking towards our community partners as well, with being able to move the veterans from our community into the FQHC. In terms of then thinking about what it means for something to be a best practice, we utilized a quadruple aim approach. So the quadruple aim highlights kind of four things that we want to achieve in a best practice. We want to see an improvement in health outcomes. We do want to see an improvement in per capita cost of care. We want to see an improvement in care experience of the veteran population, but we also want to see improvement in care experience of the clinicians that are providing care. So as we looked at as we're starting to gather information about these different types of practices that exist, how do we actually, of these quadruple aims, how many of them are we hitting? And then based on that, how are we going to then categorize it as emerging versus a promising versus a best practice. So go to the next slide, please. So as I said, there's actually very little information that's currently available regarding the dental services that veterans receive, especially outside the VA healthcare system. And there's limited opportunity for the dental home outside the VA healthcare system. So that's why we're turning to FQHCs. And to help FQHCs be able to really engage with this population, we want to make sure that they have a valuable resource to do that. We know that these evidence-based practices can eventually lead to system changes that will improve health outcomes and improve the cost per capita and improve patient care experience and clinician experience. But helping FQHCs understand how to implement these programs and providing a resource for them is paramount to that being successful. All right, and we'll go to the next slide, please. Next slide. One more, please. There we go. Okay. So like I said, so looking at FQHCs as viable access point for veterans and identifying emerging and promising practice can help FQHCs engage with these veteran populations, ultimately hoping that this will lead to an improvement in dental care and be able to improve the oral health status of the veteran population and identify better opportunities for system change with how our veterans are able to access dental care. So next slide, please. So where we're at this process now is as we've kind of finalized our emerging, I don't know, I'm having struggles with that word today, emerging, promising, and best practices as we kind of finalize that criteria, and being able to develop a survey instrument where we can reach out to health centers to determine ones that are already engaging with veteran populations and what practices they're utilizing and how we can make that information available to others. AIDPH is currently working with the National Network for Oral Health Access to develop an online resource for FQHCs who are interested in engaging with veteran populations. And being able to create a promising practice guide for veteran oral health when it comes to FQHCs. And we're hoping to have that ready for release in spring of 2023.
McAllister, I just want to give you a 1 minute warning.
Oh, thank you. Yes. All right. And well, that's a good thing because I was just about to wrap up too. So if you are interested or if you are involved in a health center that does serve a veteran population or you have a strong veteran population, please do reach out to us. We'd love to hear from you. We're conducting some targeted interviews, and we are, as I said, finalizing our survey instrument to help us be able to work with a advisory board of key stakeholders to be able to create this guide and that resource. So thank you, everyone. And
thank you, McAllister. And McAllister actually needs to leave us a little early. So I'm going to just veer off the plan here and just flag a question that came in for you, McAllister, before we lose you. How many of those vets that qualify are getting care? I wasn't sure if that was defined. Which veterans are we trying to reach? That's the question.
That's a really excellent question. So in terms of the veterans that qualify within the VA healthcare system, I'm assuming that's what you're asking, Teresa. We don't have a lot of information, at least I couldn't find recent information regarding that. I know the VA healthcare system, much like pretty much every dental clinic, is facing staffing shortages, and that is impacting access to care as well. So there's a lot of the same challenges that we see in general population access to care. We see even the same thing reflect in the VA healthcare system, unfortunately. So we're trying to target the veterans who don't qualify for care at the VA healthcare system, but and maybe don't even qualify for other dental benefits, but it's a very confusing system to navigate. So there's one of the things that we need to work on is being able to develop resources to help navigate those systems too.
Great, thank you. And thank you, McAllister. Fabulous presentation. Okay, we're going to move on to our next presenter now. We're going to hear from Denijah Miller. Denijah is a 2019 graduate of Howard University with a Bachelor of Science in Biology. She's currently in her second year of her MPH program at Howard University. Denijah has 3 years of experience working with the DC government and is a full-time employee at DC Health as a health licensing specialist in the Department of Health Regulation and Licensing Administration. Her interests focus on oral health and health disparities in minority populations and underrepresented communities. Take it away, Denijah.
Thank you so much for that introduction, Stacy. Hello, everyone. Again, my name is Denijah Miller, and today I will be presenting on my summer research project, which was developing a oral health and education survey that focused on the LGBTQIA+ community. Next slide, please. All right, just to give a little background. So according to the US Census Bureau, there are about 332 million people within the United States, and about 7.1% of the population identify as lesbian, gay, bisexual, transgender, queer, intersex, or asexual. While the term is used as an umbrella term and the health needs of this community are often grouped together, each of these letters represents a distinct population with its own health concerns. The LGBTQ population has been identified as a health disparity population due to being at greater risk of developing behavioral and physical health issues, but it's also primarily due to lowered access to health care. Unfortunately, some of this comes down to the LGBTQ+ community avoiding treatment due to past discrimination and fear of stigma. And according to the Center of American Progress, they indicated that discrimination experienced by this community largely impacts their ability and intent to access care. So on the other side, we have an example from a cross-sectional study, and you can find the link below in the chat. This study was focusing on reviewing challenges in access to oral health services among the LGBTQ+ community in Indiana and Michigan. And here are some of the results. So while 71% of members reported visiting the dentist regularly, about 43% of those individuals reported feeling uncomfortable and when going to dental appointments, and 34% of these individuals reported being treated unfairly during appointments due to sexual orientation or due to their sexual orientation orientation. So with these and looking at this cross-sectional study and looking at the results, we do see that it is important to conduct this type of research to enhance and improve dental environments to increase quality of care within this community. Next slide, please. All right, so we're going to get into the purpose, and the purpose of the LGBTQIA plus oral health and education survey was to understand the knowledge, attitudes, and comfort levels in working with the LGBTQ plus community among the oral health community. We also wanted to identify current gaps and opportunities to develop resources that meet the needs of the LGBTQ plus community within dental education environments. And we also wanted to determine next steps for additional research of oral health professionals regarding attitudes and resources for the LGBTQ plus community's oral health. Next slide, please. All right, as far as the methodology, the sample we wanted to look at was the oral health community. So some of the participants were dental professionals, educators, and students. We wanted to recruit them using the professional listserv of AIDPH and also look or send out the survey to schools and universities such as Howard University School of Dentistry, University of Maryland, and Meharry College of Dentistry. As far as data collection procedures, we used the electronic survey, which was disseminated onto SurveyMonkey. And we had 5 specific aims for this survey. We wanted to focus on, again, the knowledge, attitudes, comfort levels, their dental education environment, and current resources that they were aware of. And just to let everyone know, for the purposes of this presentation, we will be just focusing on the preliminary results and not the implications of the dental education or surrounding dental education. Next slide, please. All right, so as far as the preliminary findings for knowledge, as of today, there were about 215 respondents that completed the LGBTQIA plus oral health and education survey. So as far as knowledge, oral health professionals had the weakest knowledge around clinical terminology, which was almost about 20% of the respondents said they had no knowledge or their knowledge was very weak. And the same thing goes for social emotional needs. We can see here that the cultural terminology, clinical care needs, and social determinants of health were the highest areas of knowledge. But becoming familiar and knowledgeable with becoming familiar and knowledgeable about clinical terminology among this population can allow for providers to provide the community with the highest quality of care. And as far as social emotional needs, we know that this population experiences personal and structural barriers that interfere with the abilities to access the highest quality of care. So it is equally important that dental professionals and the oral health community in general are aware of clinical terminology and their social emotional needs. Next slide, please. All right. And some of the questions that we asked surrounding the attitudes of the oral health community. We wanted to look at the explicit attitudes from the oral health community. So we asked questions surrounding challenges that they face working with the LGBTQ plus community, and what do they believe are the major obstacles for this community to obtain optimal care. So the word cloud just depicts some of the responses provided by members of the oral health community. Another question that we developed in the survey asked if LGBTQ plus people face the same oral health concerns as non-LGBTQ plus people. And based on the responses provided from the oral health community, the answers were split, meaning that some believe that they did have the same oral health concerns and some believe that they didn't. And as we know from research has shown that the LGBTQ plus members face disparate health outcomes due to bias, stigma, and discrimination. So we can see that there is a demonstrated gap in awareness from the oral health community. Next slide, please. All right, and as far as comfort levels, so the preliminary findings for comfort levels suggested that members of the oral health community are more comfortable working with straight and heterosexual adults and youth rather than working with the LGBTQ plus members. And it also suggested that 50% of respondents reported being extremely comfortable working with LGBTQIA plus patients in a professional professional and personal capacity. Now, these results displayed comfort in working with the LGBTQ plus members, but less than 5% reported being not at all or not so comfortable working with this community. And while the percentage is small, it is still enough to impact LGBTQ plus members' quality of care. Next slide, please. All right, and as far as key takeaways from the survey, so the survey suggested some oral health professionals are completely unaware of LGBTQIA plus health and oral health needs, that this population or the LGBTQIA plus education and cultural competence is highly necessary in dental environments and should be taken into consideration in all aspects. This also suggested that continuous research should be conducted on LGBTQ plus individuals' dental disparities. And we also see that more research should be conducted on these dental disparities, as well as recruiting individuals to be a part of this community to increase comfort and awareness of this special population. We do know that representation matters, and LGBTQ plus providers will be more attuned to their LGBTQ plus patients' needs. Next slide, please. And as far as a call to action, the LGBTQIA plus dental education survey provided insight on how members of the oral health community engage with the members of the LGBTQ plus community. This survey also highlighted the need for knowledge and awareness expansion among the oral health community. The survey can be used to improve dental environments in a positive way. And some of the next steps I would suggest would be to use the survey to enhance knowledge among this community by including LGBTQIA plus population care in dental schools and dental programs. We also want to possibly require continuing education courses and resource opportunities about the LGBTQ plus population due to new emerging concerns, and continue performing research that supports the necessity for dental professionals to demonstrate greater cultural humility and competency while working with this community. And that is the end of my presentation. Thank you all so much.
Thank you, Janaja. That was wonderful.
No problem.
We're now going to turn to our fourth and final presenter, Elizabeth Alpert. Elizabeth graduated from the University of Buffalo School of Dental Medicine before pursuing a 2-year general practice residency at the University of Washington. She also completed a year-long fellowship in leadership education in neurodevelopmental and related disabilities, and graduated with a Master of Public Health degree in health policy from the Harvard T.H. Chan School of Public Health. Deeply passionate about public health and addressing oral disparities, she divides her time between clinical practice, academics, and research. She practices general dentistry as well. We're going to turn it over to Elizabeth.
Thank you, Stacy. For my project, I worked on a cross-sectional analysis of Paycheck Protection Program, PPP data, relief funding for veteran-owned dental businesses. Next slide, please. So we know that COVID profoundly impacted the US dental care system in multiple domains, including education, financing, regulation, and care delivery. The pandemic exacerbated dental staffing shortages, which greatly affected care delivery. There were multiple federal funding mechanisms designed to support US small businesses, including the Paycheck Protection Program, PPP, Economic Injury Disaster Loan Program, EIDL, and American Rescue Plan Act, ARPA funding. Over 90% of dental private practices utilized PPP funding, which was implemented by the US Small Business Administration. This program provided small businesses with funds to pay up to 8 weeks of payroll costs, including benefits, as well as interest on mortgages, rent, and utilities. And it also included provisions for full loan forgiveness. After the PPP program was initially implemented, Congress and the Small Business Administration implemented some changes designed to help traditionally underserved businesses receive more funding, including those owned by veterans, minority racial and ethnic groups, and women. In the literature, there's been some state level analysis of dental businesses and different levels of federal COVID relief funding, but nothing on a national scale. And on a national scale, there has been some investigations into different lending patterns, but nothing specific to dental businesses. Next slide, please. The first objective of our study was to examine differences in PPP funding between veteran and non-veteran owned dental care delivery businesses and organizations. Secondly, we also wanted to look at other factors that were associated with different funding levels. We had hypothesized that dental businesses owned by veterans, minority racial and ethnic groups, and women would receive higher levels of funding since the Small Business Administration had implemented program measures to try to facilitate more lending for these groups. So we looked at all of publicly available PPP loan level data throughout the entire program. Our only inclusion criteria was to look at self-identified dental care delivery businesses and organizations. And this left us with a sample size of just over 132,000 observations. Next slide, please. All data for analysis was obtained from the publicly available PPP loan data and was self-certified by applicants for accuracy. So our primary exposure was veteran status. We looked at two outcomes, both PPP loan approval amount and PPP loan forgiveness amount, both in dollars. We considered covariates of race, ethnicity, gender, rurality, which was a dichotomous indicator of rural or urban, of dichotomous indicator of income status, which was low and moderate income versus high income. We looked at number of employees of business, the loan processing method, which is if funding was received in the first or second round of the program. We looked at the dental business type and lender type. So for lender type, we had broken this down into either top 5 traditional banks, top 5 alternative lenders, which were the top 5 non-traditional depository institutes providing lending, or all other lenders. Next slide, please. So if we first looked at some descriptive statistics to examine a breakdown of all PPP lending for all dental businesses, as well as self-identified veteran-owned dental businesses, and also looked at the covariates of interest for each group. In coming up with the ultimate analytical approaches, we used kind of a combination of factors to come up with 3 different approaches. So we completed either bivariable or multivariable regression analyses. Unadjusted models involved no statistical controls, but adjusted models adjusted for the covariates previously mentioned, including race, ethnicity, gender, business characteristics, and loan characteristics. When we started looking at the data, one thing that jumped out right away was the number of missing missing pieces of demographic information. So there were a very significant number of businesses that did not report their race, ethnicity, veteran status, or gender. So we basically ran one set of models with all observations included, and we ran a second set of models when we restricted the study sample to with no missing demographic observations. Next slide, please. So as I mentioned, the preliminary complete study sample was just over 132,000 dental businesses. About 3,500 of those self-identified as veteran-owned, and just over 23,000 of those businesses actually had the complete set of demographic information. Overall average loan size for all businesses in PPP funding was about $41,000. We saw that this was significantly higher looking at dental businesses. Average loan size among dental businesses was closer to $87,000, and even higher among veteran-owned dental businesses at about $89,000. Next slide, please. So in the first model, which was an unadjusted model looking at all observations, we did not find a statistically significant association between veteran status in either outcome of loan amount or forgiveness amount. Next slide. Thank you. In the second model, when we looked at all data, but adjusted for our specified covariates, again, we didn't find a significant association between veteran status and funding amount or forgiveness amount, but we did see that minority, racial, and ethnic groups and women both received less funding and had smaller amounts of loans forgiven. We saw that rural businesses actually received more funding and had higher amounts of loans forgiven. Next slide, please. In the next model, this was unadjusted, but restricted to only observations with all demographic characteristics reported. Again, we didn't find a significant association between veteran status and funding amount or forgiveness amount. Next slide. And in our final model, when we had excluded all observations with missing demographic information and adjusted for our specified covariates, we did find that both veteran-owned and rural dental businesses received more funding and had larger amounts of loans forgiven. We did see the same trend with minority, racial, and ethnic groups and women-owned businesses, where they had also received less funding and had smaller amounts of loans forgiven. Next slide, please. So to our knowledge, this was the first comprehensive analysis of all dental recipients of PPP funding throughout the United States. We saw in our final model that veterans and rural dental businesses were ultimately helped. But unfortunately, we also saw disparities in funding that meant that dental businesses owned by women and other racially minoritized people did not receive adequate funding for their dental businesses. When they did receive funding, the businesses actually received lower amounts of forgiveness for the PPP loans. So to our knowledge, this is contributing to the body of literature on disparities in lending of PPP funding. And last slide, please. As far as next steps, it'd be really interesting to look at other federal funding, COVID relief funding, see if these same patterns are applicable. And specifically with the PPP data, it'd be interesting to combine it with other data sources to actually provide more of a program evaluation analysis and to look at implications of PPP funding ultimately on oral health equity. And that's it for me. Thank you, Stacy. And thanks, everybody.
Thank you. That was terrific. And thank you to folks who have started posting questions in the chat. I'm now going to turn it over to Annalise Cothran, the Executive Director of AIDPH, who's going to lead us through some questions and discussion.
Thanks so much, Stacy. So I do want to encourage everyone to add questions in the chat. And I know there are some specific questions for Denijah. So before we get into those specific questions, I think I just wanted to add an opportunity for everybody to respond as you went through your research. Maybe what surprised you the most about what you saw and what the key takeaways were as part of your learning experience of the summer fellowship. And we can just popcorn that. I'm going to go around the screen. Elizabeth, what surprised you the most about your research?
I think coming from a clinical perspective, I had certain ideas about what I would expect to see in the research. And then when you actually look at what data is available to try to test out the questions that you think are interesting from a clinical perspective, I thought it was really interesting to try to come up with approaches to try to tackle what you see in one-on-one patient interactions.
I love that. Great takeaway. Pamela, what surprised you the most about your research or what you learned through the fellowship?
Yes, so I would have thought that these health disparities would be skewed towards just the people with lower incomes and people who resided in rural areas. But when we mapped and found out that they were distributed nationwide, I guess that was that was an interesting fact for me to find.
Great, thank you. Denisha, what would you like to add?
I guess I could say what was most surprising about the research was finding out that some of the oral health community did not even know any of the oral health needs of the LGBTQ plus community, or that they were unaware of some of the terminology that goes with the LGBTQ plus community. So that surprised me a lot, and just showed that there needs to be more education and training surrounding this community.
Thanks, Denisha. So I'm going to go to some of the specific questions in the chat. The first one I see here is for Pamela. Did you look at the relative frequencies of the oral health conditions among veterans, and which ones were the most common?
Yes, so dental pain was the most common, followed by any kind of cavities. Yeah.
Great, thanks, Pamela. And I will remind everyone in the audience today that these research projects, some of them were very comprehensive, and they're just presenting a little slice of what they learned today so that everybody could get in and present key takeaways. So a lot of these research findings are far more comprehensive, and there's more information to share later as we continue. Denisha, there were two questions for you in the chat. One was, are you considering research around how, or do you have information about how oral health providers and staff are collecting data on sexual orientation or gender identity, and then how they may be using that in patient care? And then a second question, which is, do you have a sense of how oral health providers may compare to other healthcare providers?
Okay, so to answer the first question, I would say that that's not something I was considering until after the survey was completed. I definitely think that it's important to understand how their dental environments are collecting this information, and just to see if they are collecting this information, just so that they can improve and enhance the quality of care for these individuals, as well as improve their dental environments to make it more comfortable for them to want to come and receive care if they're in dental pain, dental discomfort, or just regular dental appointments. So I definitely will be considering furthering my research in that area, just to see, how they are collecting that data and how they're using that. So definitely. And then for the second question, do you have a sense of how dental providers' level of comfort treating this community compared with level of comfort among other healthcare providers? So the research and the literature that I looked at suggested that medical staff, nursing, and dental staff are all around the same, have the same level of comfort regarding the LGBTQ plus community, and that they all, or that these communities should continue to, I guess, further educate themselves on how to provide care for these communities. There should be more education in all aspects of health, because obviously oral health is a part of your overall health. So it didn't really give too much information on like exact statistics and numbers of their comfort levels compared to oral health community, but it did suggest that these communities or these healthcare providers do need to be educated more, need more training on how to provide care for this community. So yeah.
Thanks, Denisha. Elizabeth, I do have a question for you. I know through the process of going through your data collection, I was really surprised and also not surprised, unfortunately, by the outcome. I know originally we had posited our veterans and people who run dental businesses in rural areas, are they getting the support that they need? And I think it was such a success to see that the data sort of substantiated that they were. And then unfortunately, we saw that there were disparate outcomes for minority-owned businesses and women-owned dental businesses, both in funding plus forgiveness. I wonder if maybe you could just posit what that means in the real world for minority-owned dental businesses and for women-owned dental businesses, what that potential implication may mean, and what we as an oral health community should be considering for that.
Yeah, it was definitely a very discouraging finding, especially because the Small Business Association had kind of come out with some information saying we looked at initial loans and we see that this is a problem. So here's the list of strategies we are going to try to do to address it. And the fact that even after those strategies were implemented, which kind of included a lot more outreach to different underserved community groups, including trying to expand what type of lenders would be available for funding, that those approaches didn't work. I think that was like especially discouraging. One thing to think about too is that the publicly available PPP data that was released didn't actually include loans that were rejected or canceled. So I think knowing like if those disparities persisted within that broader loan pool, I think that would probably give us some more information on what conclusions to draw. I think there was a second part to your question that I did not remember.
How do you feel like we as an oral health community should be responding when we notice that disparity?
Yeah, I mean, I think we should be amplifying that this is a problem. I think a lot of dental businesses, like a lot of dentists, like the focus isn't necessarily on promoting oral health equity across like all dental businesses. So I think like step one is just trying to expand knowledge among dental providers and healthcare providers in general, that there are these disparities, and trying to connect those also to like disparities in patient, ultimately like patient care. I think that would be really important.
Yeah, that's a great point. Thank you, everyone. I really appreciate all of your insight and all of your hard work over the past several weeks. I know AIDPH has really enjoyed having such a wonderful fellowship group, including McAllister, even though she's not here. I truly want to acknowledge how fun it's been to work with each of the summer fellows and how excited we are to be celebrating their successes and their progress in the program. So before we close out today, Jasmine, would it be okay if you projected the slides again? Before we closed out today, we did want to acknowledge our partners that we work with frequently on these research projects and others, one of whom being CareQuest Institute for Oral Health, a strategic partner for us in our Veteran Oral Health Initiative, the National Network for Oral Health Access, who we are partnering with to develop best practices for veteran oral health and FQHCs, and then the LGBTQIA+ Learning Collaborative, which AIDPH facilitates within the Open Network, or within Open, the Oral Health Progress and Equity Network, who supported and advised the development of the LGBTQ+ survey that was disseminated. And then lastly, we wanted to remind everybody that continuing education credits are available for today's session. And so if you are interested in having continuing education provided by AIDPH, Anna has posted in the chat the evaluation request and CEU request. And with that, I will say thank you and close us out for today. We appreciate you all attending.